50s up to the 100s. Hospital beds in use due to COVID-19 decreased again yesterday. There was just a slight increase in the number of ICU beds in use, but overall 20 fewer beds total in use. So there are currently 645 people in Minnesota hospitals being treated for COVID-19 specifically. Of those, 131 are in intensive care. The 7-day rolling average number of Minnesotans with COVID-19 admitted to the hospital has been stable and declining slightly. So these are both reassuring signs in terms of the beds in use and the average number of admissions declining slightly. Cumulatively, there have now been 23,113 patients hospitalized for COVID-19, and 4,836 of them have required intensive care. Just a short vaccine update today. Following some significant changes in federal guidance on vaccine distribution a couple of days ago, just today we have informed our vaccination partners, hospitals, healthcare systems, local public health, and others, that they can begin to provide vaccines to broader categories of Minnesotans, including those 65 years of age and older. Today's announcement is designed simply to remove barriers to healthcare providers and other vaccination partners who have available doses to be able to use those doses as quickly as possible while still ensuring that the doses we have are targeted to those most at need for protection from COVID-19. We've been hearing feedback from some of our partners that as they have made good progress on getting through some of these earliest stages of the vaccine rollout, they would like the flexibility to use any additional doses they have on these additional populations that the federal government has told us we are able to make a priority. So we are approaching the end of our earliest stages of the vaccine rollout and are pleased with the progress that's been made among healthcare workers and residents and staff of skilled nursing facilities in particular. And we are just beginning to now begin vaccinating in assisted living facilities as well this week. So as we approach the end of some of these first priority groups, we want to make sure that all the vaccines in the state are able to get distributed to Minnesotans as quickly as possible. So today's announcement and guidance to vaccine partners is simply to make sure that they have nothing holding them back from immediately using any and all vaccine that they have available. That said, the reality is that we have far more Minnesotans eligible for getting the vaccine than we have doses available from the federal government. We have been working to get ready, and we are ready to get more vaccines out very quickly. But now we really need for the federal government to step up and provide us with additional supply of vaccine to make that possible. We will be announcing in the coming days more information on the next phases of vaccine rollout and how we will be serving expanded populations. And again, that more information on that will be coming in the next days. I do want to underscore again how important it is that we have increased supply of vaccine from the federal level coming, that is just critical for our ability to deliver on the expanded priority population that we also are eager to serve. We are ready to move on any additional supply that we get immediately, and we're working quickly to create new options for Minnesotans to know where and how to get vaccine. Minnesotans can continue to find more vaccine information on the state's COVID-19 response website. And again, we will be updating you with additional information in the coming days. With that, I'd like to turn it over to Dr. Ruth Linfield to update on clinical issues related to COVID-19. Ruth.
Thank you very much, Commissioner. So I have discussed the multi-system inflammatory syndrome occurring in children and promised to give intermittent updates on that. And so today I will be providing an update on MIS-C. Nationally, CDC has reported 1,659 cases and 26 deaths of the multi-system inflammatory syndrome in children, and their latest update occurred on January 8th. In Minnesota, we have had 56 confirmed cases. We have not had any deaths. Our average age is 7.5, but the range is wide from 6 months to 20 years. 73% are male, and we continue to see a disparity amongst minorities, so that 60% of our MIS-C cases are Black or Hispanic children. In general, because the number of MIS-C cases is related to the overall number of COVID-19 cases and develops about 4 to 6 weeks after infection, we are seeing more MIS-C cases now than last fall. However, I want to remind you that it is still extremely rare. 56 cases out of more than 72,000 cases of COVID-19 in children aged 0 to 19 years, or less than 0.1%. To remind you, children may present with a variety of symptoms, but most typical are prolonged fever, usually at least 3 days, rash, abdominal pain, nausea, vomiting, diarrhea, red eyes, and significant fatigue. Children may not have a known history of COVID-19, as there are many asymptomatic or very mild cases in children. So it is important to be aware of this, even if there's not a known prior history of COVID. Again, I want to emphasize it is very rare. There's a similar syndrome in adults called MIS-A, multi-system inflammatory syndrome in adults. And it appears to be a condition related to COVID-19. It occurs in adults older than 21, and it is thought to be even more rare than MIS-C. It is somewhat similar to MIS-C in its presentation and clinical symptoms. Adults who have this have frequently had cardiac or heart symptoms or GI symptoms. The treatment is very similar to what we do for MIS-C, and we have heard about 5 cases of MIS-A in Minnesota. Because this is a more rare condition, we are continuing to learn more about it, and the CDC is working on a formal case definition. At this point, I'd like to turn it back to Mike Schomer.
Thank you, Dr. Linfield. Before we open it up for questions, I do have one other update that just arrived. Because of the winter weather conditions across much of the state today, we're going to need to make some adjustments to the hours of the COVID-19 community testing sites in interest of testing participants and site staff safety. As of now, the sites affected are Albert Lee, which is closing at 3:30. All appointments after 3:30 have been canceled. Morris, closing at 2:30. All appointments after 2:30 canceled. Worthington, closing at 3:30. All appointments after 3:30 canceled. Officials are assessing the conditions for this afternoon and tomorrow at all sites. If you were planning to get tested today or tomorrow, the best advice would be to check the state COVID website before you go for the most up-to-date information. Minnesotans affected by today's weather are encouraged to stay home if they don't need to be tested, or if a test is needed, consider rescheduling for a later date on the state's COVID response website. As a reminder, people can also use the state's no-cost test at home program. Anyone can request a test kit on the MDH website. So with that quick announcement, we will open it up for questions or questions.
At this time, I would like to remind everyone, in order to ask a question, press star, then number 1 on your telephone keypad. Again, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. There are no questions at this time. Mr. Schomer, you may continue.
Yeah, I wonder if we might be having a technical glitch, but we'll just wait another moment, operator, if we could, to see if any questions do come into the queue. Operator, do we have questions at this point?
Yes, sir. Your first question comes from the line of Mr. Jeremy Alton of Star Tribune. The line is open. You may ask your question.
Yeah, sorry, I don't know what the technical hitch was there. Question about the new guidance on 65 and older. I mean, have you just created a start your engine situation by which every senior citizen is going to be bombarding their provider with requests for vaccine? I mean, especially with vaccine in short supply, are we even ready to throw it open like we just did?
Well, thanks, Jeremy, for the question. It helps me just help clarify the intent of today's guidance to providers. This is not the unveiling of our next steps in the expansion for which, as we've said, we've been planning for some time. But the federal announcement that directs us to move more quickly on expanding eligibility, and we're working on the details of that, and we'll be announcing more about that in the next coming few days here. Today's announcement was specifically to make sure that providers, and we have heard from some that have made good progress getting through the priority tiers among healthcare workers. So I'm really just talking about that side of 1A that has to do with healthcare workers. The long-term care program, as we've discussed, is sort of a whole separate track. So just talking about those who are vaccinating healthcare workers, we've heard from some of them that they've made good progress through the priority tiers and have some doses available, and have been asking for flexibility to use those doses. And we are simply saying today that we want to remove any barriers to their use. We will be communicating much more broadly with Minnesotans about how we will be making more opportunities available for the expanded populations. And as we have talked about, and you've rightly picked up on, our ability to actually provide vaccine to those expanded population groups is going to depend, how quickly we can do that is going to depend entirely on how quickly the supply of vaccines can ramp up. But we just simply want to make sure that any doses that are available for use right now can be put to use by those providers who have them.
So it's more of a top-down approach. If doctors have leftover vaccine, they can provide it to available patients rather than ground up where patients should call and start scheduling.
Thanks, Jeremy. I think that's a helpful characterization. Yes, I mean, today's announcement is really for providers to give them the flexibility to do that. We are not yet ready to advise large groups of Minnesotans on how they can get vaccine. Those systems are being stood up as we speak. We've been, as I've said, planning for quite a long time about how we would ramp up more vaccination sites. The healthcare providers are working with us. Local public health is working with us. Everybody's getting ready to create more capacity to vaccinate. But now we need the supply of vaccine to increase so that we can move through these priority groups more quickly.
Quick squeeze one more question, and then with the starting assisted living, can you give a status update on the PPP program? I mean, are we reaching an odd situation now where we're going to start vaccinating in assisted living homes while we're still waiting to do some nursing homes through that program?
We are, as we've talked about, a little hampered by the lack of a lot of data of specifics on how the PPP program is doing in terms of how many facilities have been vaccinated and what remains. But we are anticipating getting better information on that from the federal government. And we also have a survey out with the help of the long-term care associations directly out to facilities to inquire about their status. So we should have better data on how we're doing on skilled nursing facilities coming in by the end of this week. But absolutely with those who are not being served by the PPP and assisted living, it's our priority is to get to all of the congregate care populations just as quickly as we can. And as we've been forecasting, our hope and intent is to get through at least first doses or scheduled first doses for that entire long-term care population by the end of January.
Thank you.
The next question comes from the line of Mr. Bill Werner of Minnesota. The line is open. You may ask your question.
Thank you. Commissioner, I'd like to follow up on just the question that my colleague asked, just so that I want to get a better understanding of this. It sounds like what you're saying is that in some areas of Minnesota, they've gotten through the 1A group and they still have some vaccinations that are unclaimed, as it were, or unused. Am I correct on that? And if that is the case, can you get that vaccine over to areas where all the 1As have not yet been vaccinated? Maybe that's a logistical problem and you can't do that. Or short of that, I know this is a tough problem, but can you say enhance your tracking system so that in the future, as we get into 1B and the other categories, that you can better marshal the vaccines in the needed areas?
Well, those are good questions, and indeed we are learning a lot from these first weeks of vaccination and working to improve the information system in which vaccine information is entered, so that we can get more helpful analytic data out of it as to how we're doing at a more granular level, where the doses are being used more quickly and less quickly, and so forth. So we're working to try to improve the information. I think we've talked a lot on these calls about how confusing it is to unpack the numbers of all the doses that the federal government has promised to us versus what's actually here. When did it arrive? For instance, in the amount that was that has been shipped to Minnesota providers that you can see on the vaccine website, a significant amount of it just arrived like 2 days ago. So it'd be useful to know, for how long the vaccine has been, at its ultimate point of use out in the vaccination sites, and that's something we just don't have yet in the data. So I think today's announcement really was, and we are talking about small, that's an important point to make here too. We're talking about small numbers of doses that some providers and some local public health agencies have told us they would be able to use to help vaccinate priority populations because they're through with their version of 1A. But that is those are small numbers, and as Jeremy said, I think it's really more to give the providers flexibility to use what little extra they may have right now, rather than waiting for permission from us to expand.
Just so we're clear, Commissioner, so that some locations may have gotten through 1A, but there are others that have not. Is that correct? And are in need of vaccine? And is it not logistically possible to take those extra? I know it's only a few doses, and maybe is it not practical to put it send it to another location then?
We do try to do some of that every week when we get the new numbers from the federal government in terms of what's coming the following week. We do try to. We're in contact with the regional coalitions who are in contact with all the vaccinators in that region about the progress that they're making and how far they are through the priority population. So we do make some adjustments in the allocations regionally, and then the coalitions to their providers based on who hasn't been able to get through priority populations yet. So to a certain degree, we are doing that reallocation. But what we're talking about today, just with the relatively few unclaimed, if you will, doses that a provider may have left at the end of the process, so to speak, on a day or a week, that we just simply want to give them the flexibility to use that locally. So yes, I think for the type of situation that we're talking about here, we don't think that it's logistically makes much sense to try to move those relatively few doses around, but we do that through the kind of the weekly process.
Understand it, and in anticipation as opposed to before they've been distributed out to the providers, what you're saying.
Correct.
Yeah, okay. Thank you much, Commissioner. I appreciate all the time.
Your next question comes from the line of Ms. Catherine Ricker of Minnesota Public Radio. Your line is open. You may ask your question.
Thank you. What does this mean for Group 1B, which includes teachers, police and firefighters, those sorts of people? Does this mean that people 65 and older come before them now or simultaneously? What's your prediction there? Or what's your hope? What would you like to see happen?
Sure. Thanks, Catherine. I mean, I think that's what's important about distinguishing today's relatively focused announcement that's hopefully helpful to those providers who may be able to use some of their doses, as we've been talking about. That's different than saying what is the plan for 1B. That is what we're continuing to work on in light of the federal changes from earlier this week, and that we don't have that announcement ready for today. That's what I was indicating we would be communicating about in the coming days. We're still working through what is the implication for the large, very large populations that the federal government have just kind of elevated in priority, which again we think from a health risk perspective makes a lot of sense. But figuring out how that intersects with the essential worker categories is what we are still working through in these next couple days.
To that end, are you also expecting that President-elect Biden will do as he said he will, which is release more vaccines without release all the vaccine the country has right now? Are these two things so closely tied together that you can't have one without the other? Or are you anticipating that he will follow through on that?
Yes, I think that's exactly right. That the answer to the questions about how do you do these things simultaneously or in what sequence depends so much on how much vaccine is available to us. And we appreciate and applaud the idea of releasing any vaccine that's actually available. What's been unclear to us and still is unclear to us as of this moment is the amount of the available vaccine that is in fact additional vaccine above and beyond the doses that have been reserved for second doses for both Pfizer and Moderna, as you know. I mean, it's very critical that we be able to get those second doses administered to the right people in a timely fashion. And we have had, I think, over 8,000 or so people now who have completed their second dose. So that's still what we're trying to figure out is of the extra vaccine that the feds are promising, how much of it is truly, extra above and beyond second doses. So that's what we're needing clarity on from the incoming administration. And we're certainly hopeful. And one of the reasons for hope is that, as we've talked about in prior calls, there are additional vaccines in the pipeline. But we also are hopeful that vaccine production from the current manufacturers of the first two, it can be and will be and is being ramped up. But that's the detail we're awaiting from the feds.
Okay, and just one really quick clarifying question. When you say 65 and older, does that also include people with underlying health conditions, as I think Azar said on Tuesday?
Yes, that will be our intent too. And as I said, we'll be having more to say about where we go next with the next populations in the coming days. But priority populations include those 65 and older and those with underlying health conditions. The kind of operational details of how do you best identify and serve those populations are what is being worked on right now.
Okay, thank you.
Your next question comes from the line of Ms. Sue Kraft of Manaman Pioneer. Your line is open. You may ask your question.
Thank you. What is the response to those individuals in the healthcare field who are refusing to take the shot?
Well, we certainly are interested in learning about what those barriers are or what those concerns are, and we're learning a lot more about that. And I don't have really quantified data for you on that just yet in terms of what percentage, and I think it varies a lot, frankly, from area to area. I've heard different anecdotal reports from different systems about the degree to which healthcare staff are taking the opportunity to get vaccinated. I'm also hearing from many that for those that aren't taking it, it's not a refusal to ever take it. It's a desire to take it later, either because they perceive that they're at low risk and want to make it available to others first, or because they want to see how it goes in the first weeks of vaccination. So I think there's a mix of reactions. We certainly, it's incumbent on all of us to make sure that people have accurate information about the effectiveness of the vaccine, the safety of the vaccine, and why it is so very important and such an important piece of the puzzle here of how we ultimately get beyond the grip that COVID-19 has on just about everything about our healthcare system, our businesses, our civic life. So much more communicating to be done about why this is so important and why, and the fact that we talked before about the fact that some folks have questions just about, given how quickly this happened, how do we know that no corners were cut on the evaluation of the safety or the effectiveness? And those are that's information that I think credible scientific leaders are and need to be in the lead on making that case to healthcare providers and the public that these first two vaccines and the vaccines in the pipeline are going through the same rigorous process. It's just that the process itself was improved and streamlined in order to make progress more rapidly possible.
Thank you.
Operator, we have time for one more question.
Your next question comes from the line of Mr. Steve Kornowski of Associated Press. Your line is open. You may ask your question.
Yeah, hi, Commissioner. As you might know, Dr. Osterholm was on CTO radio earlier today. He said with the new UK variant, we can expect to see a very substantial increase in the number of cases here in Minnesota in the next 6 to 8 weeks. He said the worst by far of the pandemic. You agree with that? Is the situation that ominous?
Well, I did not hear that interview by Dr. Osterholm, but we talk frequently, and we are blessed to have his expertise in the national conversation. We certainly have said that this new variant is an important variable in just being realistic about the fact that while our trends are have stabilized we are still in a high risk situation, and this variant is a major new unknown in terms of what it may do here. I take Dr. Osterholm's cautions, to heart. I don't know that we have any, we don't have any specific projections that we've done about what this might do to case growth, but it's certainly one among many variables. And we just keep reinforcing that the same kind of things that help us control the spread of the existing strains are the same things that are going to help us control the spread of the new variant. That is, just paying continuing to pay close attention to the importance of social distancing, masking, staying home when sick, all of those things. There is no new strategy above and beyond the strategies that we have been employing and that we know are effective that are going to be needed or helpful with this variant, other than just keeping on doing what we've been doing and not letting down our guard. And again, we expect we'll continue to learn more about this variant, but don't have any specific quantification of what that may mean here.
Thank you. All right, that is all the time we have for this afternoon. We invite any reporters with additional questions to reach out to our office. Have a good day, and we'll be back with you again soon.